Hi, everybody. Welcome to the AIM Education Podcast. My name is Dr. Stephanie Lee. I'm a hematologist at St. Michael's Hospital at the University of Toronto and today's host. I'm joined by two of my esteemed colleagues, Drs. Castell and Bonadonna, for our second podcast entitled How We Approach Patients with Systemic Mastocytosis Who Need a Procedure. Dr. Castells is an allergist at the Mass General Brigham, and Dr. Bonadonna is an allergist at the Allergy Unit General Hospital of Vicenza in Italy. The purpose of today's podcast is to provide listeners with a framework for how to provide perioperative recommendations for their patients with systemic mastocytosis. For me, when I formulate a perioperative plan for patients who need a procedure, I break things down into four categories. I think about the patient's allergy and mastocytosis history. I think about what medications my patient's currently on and what medications I may need to add. I think about the type of procedure that's being planned and the type of anesthesia that's being planned. So with this framework, I will ask some questions to our expert panel to get a sense of how they approach patients and optimize them for procedures. So Dr. Bonadonna, what aspects of the patient's allergy history raise the biggest concerns for you that they could have a reaction during a procedure?
It is well established that patients with mastocytosis have an approximately 100-fold higher risk of anaphylaxis than in the general population. However, the most common trigger for anaphylaxis in these patients are Hymenoptera stings. An European study based on data from the European Mastocytosis Registry confirmed that Hymenoptera venom is the leading cause of anaphylaxis in patients with indolent systemic mastocytosis without skin involvement, namely bone marrow mastocytosis, whereas drugs represent the most frequent trigger in patients with advanced form of systemic mastocytosis. Overall data from European studies indicated that although drug hypersensitivity reaction are somewhat indicated that although drug hypersensitivity reaction are somewhat more common in patients with mastocytosis than in general population, they remain substantially less frequent than anaphylactic reaction triggered by Hymenoptera stings. Returning to your question, if there are some risk factors that may increase the risk of reaction during surgery, I believe that the most important risk factor is a history of a previous hypersensitivity on anaphylactic reaction during a general anesthesia. Another important factor is the presence of significant mast cell mediator related symptoms that tend to worsen under condition of physical or emotional stress. Surgery itself represents a significant stress, both because of the patient anxiety about the procedure and the ambient temperatures, which may contribute mast cell activation in these individuals. The evidence currently available in the literature does not support the notion that a history of hypersensitivity reactions to medication other than general anesthetic agent constitute a risk factor for developing the intraoperative reaction. Therefore, I think that the only risk factor is a previous reaction to general anesthesia.
Okay, thank you. Thank you very much for summarizing.
Dr. Lee, I would like to add to this, words from Dr. Bonadonna, which I totally agree that penicillin allergy, for example, is not increased. So antibiotics allergy is not increasing in patients with systemic mastocytosis. So this would not be a concern. And that a high mast cell burden, for example, an elevated tryptase, has been somehow associated with an increased risk for potentially anaphylactic reaction. So there is some sense that patients who have high tryptase levels, higher than the 20 more, would be at higher risk potentially. And the mutation, the KIT D816V mutation, a high allele burden might actually also contribute to those things. And whether whether, hereditary alpha-tryptosemia plays a role in this is actually not well established. There are some data supporting that if patients have, in addition to the mastocytosis, had positive test, they might be at higher risk for more severe events, and there are some data supporting that they might not be at that such high risk. But it is important that patients be aware if they are or not are having the extra tryptase genes.
Okay, thank you for that very thorough yet also succinct answer to that question. Dr. Castells, in terms of the patient's medications that they're taking, are there any of the typical anti-mediator medications, so antihistamines or mast cell stabilizers, that you hold before a procedure, or do you routinely ask the surgical team to continue them day of the procedure?
We ask the team to continue on the medication. So there is no medication that will be contraindicated before surgery. So even in the morning of the surgery, patients should continue to take their own medications because that's how the mast cell mediator symptoms have been controlled. And that is to be continued for that. And it's also to be continued, for example, in women who have to have a C-section or women who are going to delivery. If at all possible, they should continue all their medications, whether it's an H1 antihistamine, an H2 antihistamine, a leukotriene blocker, ketotifen, sodium cromolyn in the form of gastrochrome, omalizumab if they are on omalizumab, or even we're talking here that maybe we will discuss it. What do we do with tyrosine kinase inhibitor, which is another question.
Well, that is my next question. So what do you routinely ask patients to continue that the day of the surgery? Do you ask them to hold it and let it wash out for, what's your general, or do you individualize this based on the patient, the procedure, things like that?
Yeah, so we actually ask the patients to discontinue the tyrosine kinase inhibitor for 3 days before and 3 days after surgery. So it's about a week or so, or less than a week. The potential for the tyrosine kinase impacting in potential increase in infections or some other, the healing process also has not been well studied. And as a cautionary as a precaution, we ask them to stop that. And stopping 3 days before and 3 days after typically will not trigger mast cell activation events in the sense that the patient is still protected. But I'd love to hear what Dr. Bonadonna thinks about that. I think there is a generalized approach, but Dr. Bonadonna, do you feel this is your approach too?
Yes. In Italy, we do not have the permission to use, unfortunately, KIT inhibitors. But yes, I agree with you, especially for the slightly risk of
infection or
yes, of course, yes. But I think I agree with you, Professor Castells, that 1 week without the drug is not affect the mediator's symptom of the patients.
That's very, very helpful. What is your approach to adding medications, so sort of additional medications to try and prevent any reactions before an invasive procedure? So more specifically, do you routinely, if the patient's only on an H1 blocker, do you routinely ask them to take an H2 blocker as well, montelukast, and corticosteroids? So how do you make a decision about those additional agents in the perioperative setting?
Yeah, that's an important point. There is not a cooking recipe for everything, but there is a certain recipe that minor procedures, either dental procedures or endoscopies, colonoscopies, or other minor surgical procedures will not require steroids. So that adding another extra H1 antihistamine, like doubling potentially what the patient is on, if there is on one a day, adding that second one, adding an H2 and a leukotriene blocker is what we have recommended. and there is actually no data to compare with, but that protection has been helpful, for example, with vaccinations, and has been helpful in other instances, and we recommend that. For major surgery procedures, valve replacement, hip replacement, some other things, we add 0.5 milligrams per kilogram of steroids, and that in addition to those H1, H2 leukotriene blocker, and that seems to definitely help, avoid a mast cell activation event during surgery, because surgery is more than giving medications or the surgical procedure. It is the changes in temperature in the room. Sometimes it's too cold, sometimes it might be too hot when the patient gets out of the operating room, is the stress, the anxiety of the patient going into surgery, getting out of surgery. So all of those cannot be easily controlled. And adding the steroids does definitely help. Although, again, no control studies are available.
And do you tend to recommend steroids 12 hours before and 1 hour before, or do you have a specific view on that?
Correct. We don't do like the 17 hours as the radiology procedures, but we do like 8 to 12 hours before and then 1 hour before. Dr. Bonadonna, would you agree with that?
Yeah, yes, perfectly agree with you, Mariana. Yes, I'm perfectly agree.
And then you guys have both sort of touched on this already, but are there, in your mind, are there sort of tiers of procedures that have the highest risk ones where you are most worried about the patient reacting versus ones that are not as high risk? So I think I've already heard you say, big invasive procedure where there's a lot of skin being cut, long duration in the operating theater, are not the same as someone who's getting a wisdom tooth extracted. So are there any sort of nuances there that affect your calculus when you're making these recommendations?
I think one of the important things is what Dr. Bonadonna had mentioned at the beginning. Patients with reactions already, who have reacted to procedures, even if they have to have a minor procedure, may actually require a little bit of steroids. So again, this is very personalized medicine. Right. The dental procedures typically not, or endoscopies typically not, or minor cuts typically not. But patients who have reacted in the past and whose tryptase is elevated, the mutation burden is high, might actually require that. So we make like a statement that major surgery is the one that we will pre-medicate most, and then minor surgery we didn't, but the patients plays a big role in terms of their past medical history.
That makes great sense. It really sounds like you integrate, the patient, if the patient's reacted before or not, the nature of the procedure, and then also the patient's wishes. If they are very anxious, and having some extra antihistamine on board helps relieve that anxiety, maybe that goes a long way.
Yes, and I think there is also a really big important point about the pain relievers, because how do we deal with pain after surgery is really important to patients with mastocytosis. And in truth, if you look at Google, all patients should be avoiding nonsteroidal anti-inflammatory medication and maybe even morphine and morphine derivatives. And the truth is, Dr. Bonadonna has done seminal studies in which she has shown that only even 1/3 of the patients who have systemic mastocytosis have intolerance to nonsteroidal anti-inflammatory medication, and that morphine, even fentanyl or others, the side effects can be easily controlled with pre-medication. So I think here is one of the critical points about surgery. Before the patient gets to surgery, we need to know about those potential side effects of the nonsteroidal anti-inflammatory medications and morphine derivatives. Dr. Bonadonna, what is your assessment of that?
I'm agree.
Important work.
I'm agree, but I think that the most important thing is to provide to the patients a kind of passport, mastocytosis passport, and to explain how they have to to do before the surgical procedure, and especially do not have afraid for minor surgical procedures such as the dentist. The local anesthesia are not a risk for these patients, but I think that it's very important, especially in case of elective surgery, to speak with the anesthesiologist, with surgeon, and have a good relationship with them in order to explain that the patient do not have a high risk of reaction during the procedures.
I like the concept of a passport, because I think every patient should have a passport for surgery, for procedures, in which it said, I tolerate non-steroidals, I tolerate morphine, I need pre-medication, so on and so forth. We are doing that a lot here, but there is no universal, passport, which I think we should implement. All of us who are doing, systemic mastocytosis or seeing systemic mastocytosis patients. This is a great concept. I like it a lot.
Yes, absolutely. So I want to thank you both for sharing your experience and your perspective on this challenging topic. And it sounds like the takeaway message for me, at least, is if a patient needs a procedure, they should be offered the procedure, per standard of care. Maybe there are some situations where the risk of having reactions is higher, but with good planning and good communication with the surgical team and communication with the patient, we definitely have tools to optimize them. And, we have to, these patients still deserve to be offered these procedures. And so thank you. Does that sound like a fair summary?
Yeah, no, I think that you described it very well. I do think that this is a multi-specialty collaboration. We really need to create that sense of, community for the taking care of the patient that involves the anesthesia, the surgeon, the hematologist, the allergist, and the patient itself, in terms of knowing that we are taking care of, because there is a true risk, as Dr. Bonadonna said, of patients with systemic mastocytosis having reactions. And we have to identify those patients, we have to protect them, and we have to make sure that they get standard of care for all the surgeries that they need.
Perfect way to close out this podcast. So thank you both again so much for joining. It was a real pleasure to get to speak with you both about this. And I'm sure listeners will really find this very informative. So thank you again, and we'll see everybody at the next podcast next quarter.
Thank you so much, Dr. Lee, for your leadership. Yes, thank you.
This program is supported by Cogent Biosciences. Cogent is committed to advancing research in genetically driven hematologic diseases, including systemic mastocytosis, by collaborating with the medical community to help improve awareness, understanding, and patient outcomes. Summit is a Cogent-sponsored clinical trial evaluating the investigational therapy bezuclastinib in patients with non-advanced systemic mastocytosis. The FDA has accepted the new drug application of bezuclastinib and has assigned a PDUFA target action date of December 30th, 2026. To learn more, visit cogentbio.com.